Hi, this is Carol, and I would like to share some information with you on my research project. I completed a definitive study on technology and simulation mannequin use in respiratory care programs. Specifically, I was working on um, trying to define the use of technology and simulation mannequin use in respiratory care programs and determine if a relationship existed between using simulation mannequins and the RRT success rates. I used a survey to collect data for this. I asked about student use of technology, program faculty use, and simulation mannequin use, and asked them to report their program's RRT success rate. Results were not that different than what I expected, I guess, and I will talk about those later on. Um, as part of this study, I was looking at the growth of technology in healthcare and found that it mirrored basically the growth of digital technology itself. It's not just an educational issue, but for my students, it's using technology in the clinical setting. Our graduates need to be ready. They need to know how to operate equipment such as advanced life support. They need to be familiar with various digital technology, especially because they're now doing electronic charting at all the hospitals. And they're also going to be using technology to communicate with other healthcare professionals and patients. And this is going to be a big one in patient education, and also to report on the patient progress and interact with other physicians and even from one hospital to another. So my students need to be familiar with technology and provide competent patient care. So how are we going to do this with technology and simulation mannequin use? When I completed my literature review, I looked at studies on Web 2.0 tools and simulation technology used in allied health education. There really was a lack of research related specifically to respiratory care educational programs. So I just went ahead and searched in allied health education. What I found was that the wikis, blogs, and podcasts, both video and audio, seem to be the most common. There were also benefits discussed for using discussion boards, especially with communication and collaboration. Availability of technology and confidentiality risks were a concern. And, again, we're in a health setting, and a lot of the computers in the hospitals have firewalls and certain programs that are blocked. So the Web 2.0 tools sometimes may be difficult to actually use due to that. And also we have to be concerned about patient confidentiality, so we do need to watch what we put out there for technology. It's a little harder again for us to use the Web 2.0 and to have something housed outside of a hospital system. Also simulation learning, and this is anything from online simulation, computer programs or software, to simulation mannequins, to the high fidelity simulation labs where multiple healthcare persons can work together to try and care for a patient. But across the board, it's used for communication, student learning, and procedure competency. Again, the purpose of the study was to define the use of technology and simulation mannequins in all the settings of respiratory care educational programs in the United States, and to determine if there was a statistical significance with the use of these mannequins and the RRT success rate. The three research questions that were put forth: what technology is being used by students, what technology is being used by teachers in the programs, and again, is there a relationship between the RRT success rate and the use of simulation mannequins? The research design and methods, I chose to do a quantitative design and obviously survey research. My population was 435 accredited RRT programs in the United States, and these programs are accredited by the Commission on Accreditation for Respiratory Care. On these 435 total programs, I selected a random sample of 250 and emailed the program directors for these programs, and they became the participants. They did have to provide consent, and basically that was just a statement that was put into an email to those program directors saying that if you complete the survey, you are agreeing to consent. Pretty simple. And then the data collection tool that I used obviously was a survey. I did use SurveyMonkey. There were actually 12 questions on the test, or on the survey, and we can pull that up and take a quick look. But pretty simple. I tried to keep it 10 minutes or less because I know I personally don't want to complete a survey that when it tells me up front I'm already 20 to 30 minutes, I can guarantee I'm pretty much not doing it. So it did limit me a little bit, but it always leaves for room for expansion for additional research later on. But you can see here they had to identify, some demographics, what type of program were they, average number of students, full-time faculty, part-time faculty. And then I asked the program directors to respond to what technology their students are using, and I gave them a list to pick from of what I thought was the most common, and then gave them an other box so they could also fill in case I missed something that most programs are using. And then I asked them to respond to what the program faculty are using in lecture, in lab, and also in clinical courses. Followed up by, are they using simulation mannequins in lecture, lab, and clinical, and the RRT success rate. Next, for results, I actually had 93 program directors respond out of the 250 that were invited to participate via email, and it's a 37% response rate, so I was pretty happy with that. For the demographics, we found that 71% were associate programs, 26% bachelor, 3% masters. Number of students in the programs range from 6 to 100, and number of full-time faculty ranging from 2 to 12, while part-time faculty range from 0 to 20. So nothing too much different than what I expected, and this percentages here actually breaks down to just about what they are for the all 435 accredited programs. That is a pretty accurate breakdown for the entire population. But I found it a little strange that there'd be 100 students in a program. That's kind of a lot, especially when we're limited by the clinical sites in the area. So I think that may have involved a satellite program or two. Now, on student use of technology, you can see here in the table, the top 4 were word processing software that was purchased, video files, clinical simulation software, and learning management systems. And you also note, wikis and blogs were used the least. I expected social media maybe to be a little higher, but obviously they're using word processing that was purchased over free, which I kind of feel bad for them, but hopefully we can educate our students on that, try and save them some money. But top 4 here, followed by audio files, discussion boards, and online clinical tracking systems. Now, table 2 looks at program faculty use of technology, and you'll see the top 4 are the same. The word processing software that was purchased, video files, clinical simulation software, and learning management systems. So you can see here that it pretty much matches up. They're using things more in lecture than lab than clinical. You can see that for each one of these. So they are color coded. And again, wikis and blogs use the least. Additional data that was obtained, we have simulation mannequin use, 42% lecture, 90% lab, and 58% in clinicals. Kind of surprised to see that there are some programs out there that are not using simulation mannequins, so that was surprising. When reporting the 2014 RRT success rate for their programs, that ranged from 11.1% to 100%. And what the success rate is it looks at how many of their graduates from 2014 actually achieve the RRT credential, which is what we want all of our students to get when they graduate. So only 11.1% for the 2014 grads seems really low. Of course, 100% is what we want to have. When comparing those success rates with the use of simulation mannequins, I used a 2-sample t-test, and you can see the results here for lecture, lab, and clinical settings, but with the alpha level of 0.05, no statistical significance was found. Points of discussion, there were a higher percentage of students using technology when compared to program faculty. So that's, again, didn't surprise me too much, but because I think our younger population of students have grown up with that, and our program faculty tend to be a little bit older. It was interesting to note that the top 4 types of technology used were the same for students and program faculty. So there was a match there. The only exception was the addition of online clinical tracking systems that was used in the clinical environment. That made the top 4, but again, that's for clinicals, so that would make sense. There was a mismatch in social media usage, with students about 40%, program faculty about 20%, and that actually is a place, I guess, where we can improve and maybe try and reach our students through social media. And also discussion board mismatch, students around 65%, program faculty around 50%, and just we'd have to follow this up with further questions, but I'm just guessing that maybe students are using discussion board in classes outside of respiratory care programs. As I noticed, wikis and blogs were used the least across the board, which conflicts with what I found for the literature review. So that's interesting to note. Simulation mannequin use was actually a little less than expected. I did expect 100% use in at least one of the categories. And then, of course, no statistical significance noted with using the mannequins when compared to the RRT success rates. Now, for limitations, I kind of, as this research went on and I was gathering the data and then starting to look at the data, there's a number of internal threats to validity that I really wish I could have limited prior to the completion of this. But, when I asked the program directors to fill out the survey, they were the ones actually supplying the data on student use of technology. So it would be interesting to note if the students were reporting that data, what difference would be seen. Also, there's varying graduation times for programs for those 2014 RRT success rates. This success rate is reported to our accrediting agency, COARC, in like the end of June of each year. So depending on when your students graduate in 2014, you either have a full year for them to get their RRT credential or potentially only 6 months, because if they're December grads, which our students are, they only have until really mid-June to get their RRT credential for it to be reported on our annual program report. So that could be a reason that there was such a variance between programs in this data. And also, there's some question on the definition of simulation mannequin. It could be high fidelity mannequins, low fidelity mannequins. Was it a full simulation lab? And although the survey was pilot tested, this somehow slipped through the cracks and could have affected the way some of the program directors responded. Conclusions and recommendations. I really think the results of the study can be used to describe current trends for technology use in respiratory care programs. It does allow for other studies to come along to investigate the best types of technologies. What is the best type to use to increase student learning for our students, to improve their patient care skills? Because we can throw technology in there, but we don't really know what's working the best. So, further studies for that would be indicated. Also, I would like to call for additional studies on the simulation mannequin use. Are they best for ensuring procedural competency, which I think is probably the biggest use right now, but is that the best fit? Should we be doing something different? And then looking at the high fidelity versus the low fidelity versus simulation labs. So what is the best way to incorporate these simulation mannequins into a program? Because these program directors are looking at trying to keep their budget low, and these simulation mannequins and simulation labs are incredibly expensive. So I definitely think there's a need to have additional studies on that to determine if it's worth all the expense. My thoughts on doing research, I do find it to be critically important in healthcare and, of course, in any environment. We need to know what's the best way to do things, and we need to have that followed up by data. We can guess, but we need to know. I think research is good because it tells us if, it allows us to try something new. If we try something new and it doesn't work, that's fine. We know it doesn't work, but we've done the research and we can move on and try something different. It allows for continuous improvement, and this is big in any program. You try new things, you do your research, and if it works and it shows improvement, great, we're improving. If it doesn't, we, again, try something different. It allows for better student learning. I mean, that's our ultimate goal here. So if we can find what works best, then we're doing the best for our students. And also, I think it's incredibly important to share your research. I can do research for myself all I want, but if I don't share that with others, no one else is going to benefit from it, and I'm just in my own little bubble. So I really believe that things should be put through publication, and share it with your peers, anyone that you can get a hold of and share it with. I've learned a number of things from this research study. I've learned that the format for doing educational research is very different from doing medical research. I was familiar with the medical aspect, but it's been a very big learning experience for me, looking at it from an educational perspective. I've also learned about the importance of validity in studies. A lot of my data, quite honestly, I'm questioning because I'm wondering, the questions in the survey, there's a few that were misleading, and did I really get the data I was wanting to get? Also, it helps confirm current practice. It lets me know what other programs are doing. I loved it. I had a couple people actually contact me individually to ask me about things we were doing in our program, and so there was a lot of discussion there with some of my peers and just, outside of the actual research topic. So that was nice. And also the importance on building on previous research. I think you can't just do one study and be done. I have a number of studies that I could add on that piggyback onto what